Please.
Welcome you to this ACNS WIN webinar that we are holding today. Our chair for the meeting, our patron is of course Professor Kato, and the chair for the meeting is Professor Ansari, who is at Aligarh University. And Dr. Sharon will be joining me if possible. She's catching a flight. So let us start the session. I will hand over the proceeding to Professor Ahmed Ansari. Ahmed, go ahead.
Yeah, thank you, Dr. Abda. Thank you, ACNS Win, for inviting me in here. Thank you, Professor Kato, Dr. Leo Raja over here. We have a very good series of lectures today. First speaker will be Professor Xiaobiao Zhang, who is the Director of Neurosurgery and Professor of Zhongshan Hospital, Fudan University. He's also a Vice Chair, Neuroendoscopy Committee of Chinese Medical Doctor Association and Vice Chair of Neurotumor Branch of Shanghai Anti-Cancer Association. He'll be speaking on surgical strategies of final region tumors. So welcome, Professor Zhang, and over to you. Can you please share your slides?
Okay.
Yeah.
Can you see my passport?
Yes, we can see the first slide.
Thanks, Professor Kito and other professors.
Yeah. Yeah.
My lecture is about surgical strategy for pineal region tumors. As you know, endoscopic neurosurgeon is inheritance of and development of micro neurosurgery. In micro neurosurgery, we create many surgical approaches and techniques. Can also use in endoscopic neurosurgery. In our department, we can use endoscopic to almost all of the surgical. This is anatomy of pineal region tumor. Pineal region, you can see this is anatomy. As you know, the diagnosis of pineal region tumor included clinical percentage, imaging, and laboratory and pathology. The laboratory examination is very important to diagnosis of pineal region tumor, such as the Yoko sick tumor have very high of beta AFP, and choroid carcinoma have very high of beta HCG. The pathology of pineal region tumor include 5 main categories, such as germinal cell tumors, pineal cell tumors, and papilloma, and glioma, and others. The pineal region tumor always found a diagnosis of obstructive hydrocephalus. This patient with the tumor and hydrocephalus. So, to pineal region tumor, we may want to treatment of hydrocephalus. Sometime, if the patient with severe of hydrocephalus and with high ICP, we may to treatment of hydrocephalus use ETV to resolve of the hydrocephalus and decrease of ICP. This is very important and believed to resect of tumor and Sept for post-operative recovery. Because of some kind of pineal region tumor, such as germinoma, maybe we may use radiotherapy. So to some patient, we can use biopsy, not resector of the tumor. Because of pineal region tumor made with hydrocephalus, so you can use ETV and biopsy. If the tumor is very large, you can use single bore hole to do ETV and biopsy. This is a typical cases. This boy with headache and others, you can see this patient with the tumor in the pineal region is with high density. You can see, and hydrocephalus. This is the MR. Can have equal signal and significant enhancement, and with some small vesicle, you can see. This tumor invasive of the ICV. This patient pre-operation diagnosis is germinoma. So we not to resect the tumor, because if you resect the tumor, totally may injury of the ICV. We can use ETV and biopsy. During ETV, after we finish the ETV, then we do biopsy of the tumor. You can see the pathology of the tumor is germinoma. This patient, we after operation we use radiotherapy to treatment of the tumor. You can see the tumor disappeared after radiotherapy. This is minimal invasive. Some patient with the tumor may be resected. We can use two surgical approaches, such as theta approaches and UTA approaches. Almost all of tumors in our department, we use theta approaches to resect the tumor. We know there are two approaches, but we likely to use theta approaches. You can see this is operation. We do in another hospital. We use perimedial theta bridges. We dissect the system, caudal germinal system, and expose the tumor. We push the tumor away from the brainstem. And we expose the supply artery. You can see the artery. Then we coagulate and cut the artery and conveniently to dissect the tumor from the midbrain. After we dissect the tumor, we can enter the pseudoventricle. This is a pseudoventricle. This is some small artery. We dissect it. We cut the artery. Into the pseudoventricle. This is the vein, draining vein, small draining vein. We like to pull the tumor from the normal tissues. This may protect of the normal tissues. We convolute it and cut the small artery. Is another artery. Draining vein may be draining to the ICV. You may have many small draining vein to ICV. We pull the tumor and convolute and cut the small vein. Don't injury of the ICV. For the tumor be free, we pull out the tumor. You can see the pseudoventricle. No, we most operation use perimedial theta for pineal region tumor. This bridge is very safety and very simple. The patient with mixed germ tumor, you have 50% of 9% of mature teratoma and 10% of germinoma. You can see This is a part of Juminoma. The teratoma may be easily dissected from the normal structures, can be totally removed. This patient with two tumors, one is in the superior sena, another is at the pineal region, but the two tumors are small and no hydrocephalus and no opportunity for ETV and biopsy. We may use perimeter theta approach to resect the tumor at the pineal region. The pathology is Juminoma, so we use radiotherapy or chemotherapy to retract treatment of the another tumor. This is after post-operation 2 years. You can see the tumor have disappeared. The other case is 17 boy with the tumor. We also use the perimedial, dissect the system of the caudal germinal. Maybe we use, we don't always use coagulation to, this may be dispute of the interface. This is a vein of pineal. We dissect the interface because these approaches to the left side it's difficult to expose the left side. So we pull the tumor from the left wall of the pseudoventricle. It is easy to expose the right side. We dissect the tumor from the tena at the roof of pseudoventricle. This part maybe carefully don't coagulate of the ICV. After dissect of the interface and free of the tumor, we remove the tumor. This is pseudoventricle. This is the mixed GCT and with two kind of pathology. This is the MR post-operation. How to resect the tumor? Because the pineal region is at the center of the skull and with a surrounding of many important structures. So we do this tumor maybe carefully. Sometimes the tumor, such as Xiaobiao, may be softer. You can use suction to resect the tumor. Sometimes the tumor be hard, maybe carefully dissect, such as teratoma, maybe carefully dissect from surrounding structures and maybe easily. Sometimes the tumor may be rich blood supply, such as hemangioblastoma. Sometimes the tumor with edema of the brainstem and thymus may carefully don't injury of the normal structures. To the tumor, sometimes we must must know a relationship of the surrounding structures, such as the ICV, the vein, and the brain tumor, thymus. It's very important to protect these structures. This is a case. This patient with very large tumors to aqueductor. We also use these perimedial approaches. We dissect the arachnoid membrane and open the caudal germinal system and expose the tumor. We use a mini retractor to help to expose this draining vein, this supply artery. We dissect the interface carefully. This is right side artery. Then we push the tumor. The tumor very large. After operation, with 5 kind of pathology. Five years after the operation, the MR shows no tumor. Another case, this patient, you can see the germinoma and the teratoma part. You can see this CT. The patient with mid high of FP, and you can see the MR with cistern, many cistern is teratoma part, and with germinoma part. This germinoma part have adhesive of the ICV. You can see we may, during the operation, we may carefully, this part may be, if we can't remove this part of the germinoma, we can use radiotherapy. You can see in the operation, this part, we can see the tumor adhesive with ICV. We may residue of the tumor. But we resect the other part of the tumor. This is a mixed GCT. So after operation, the tumor, we use radiotherapy, no tumor. Then AFP are normal. The tumor disappeared. Another case with high lutetium and with very high of AFP and build of beta HCG. This is a girl. You can see the tumor is acute density. You can see after the ETV, you can see the MR, the high enhanced tumor. You can see the tumor, another tumor at the Xiaobiao region. We resect the tumor at the posterior pineal region. This tumor we use radiotherapy. After radiotherapy and chemotherapy, the FP beta HCG are normal. Another case is 50 years female with a tumor that is a pineal region. The pre-operative diagnosis, this is maybe pineal cytoma, but at another hospital, they use VP shunting to treatment of the hydrocephalus and use gamma knife to treatment of the tumor, and also use embolism of the ICA aneurysm, the unruptured aneurysm. After the radio, after the gamma knife, the tumor bleeding, and with edema of the surrounding structures, you can see, and loss of vision. The patient to our hospital, we also use the perimedial approaches to resect the tumor. Even the tumor being treatment of the gamma knife and with bleeding, and we may also use minimal invasive treatment to the tumor. We dissect the tumor carefully. This is draining vein. This is a small artery. This is the very adhesive of the tumor with the brainstem. We carefully push the tumor away from the brainstem. We don't dissect the derma brainstem. If you dissect the brainstem, maybe injury of the brainstem after the tumor be removed. This is a post-operative MR. You can see the MR. The patient have good recovery. This is the MR. Sometimes we also use occipital transtentorial approaches to resect tumor in the pineal region, or some other tumors. We use the auto approaches can expose the anterior wall of the pseudoventricle. You can see this case, we can see many structures at the anterior wall of the pseudoventricle. You can see a afferent lobe and laminar terminalis and optical chiasm and in fundibular recesses. You can see we also use open the laminar terminalis to ETV of the patient. You can see the ACA is A1 to A1. This is a video. We use contralateral auto approaches to retract of the tumor of the pseudoventricle. We cut the tentorial. This is strep sinus. We suture of the tentorial. Then we open the caudal germinal system. This SCA. You can see in the system, we don't find the tumor at this region. We must to open the pseudoventricle to expose the tumor. We dissect when expose the pineal gland, and this is a posterior commission. We coagulate of the small vein of the pineal. In the past, we use theta approaches to push the pineal gland to expose the pseudoventricle. But now we use the alta approaches to expose this area. It is this approach can expose the pseudoventricle widening. You can see this tumor. The tumor with bleeding. Tumor very soft and may use suction to remove. The tumor be removed. The pathology is no grade glioma. Against the anterior wall of the pseudoventricle. This is natural. We use natural space to resect exposed tumor and resect the tumor. You can see the post-operative MR. Conclusion. Endoscopic neurosurgery is enhancing inheritance and development of microneurosurgery. Endoscopic surgery for pineal region show minimal invasive enhancing advantage. We can select difficult endoscopic surgical strategy for pineal region tumors. This is natural space approaches. Thank you very much. Welcome to our hospital, Shanghai Zhongshan Hospital. Thank you.
Thank you, Professor Zhang. It was a wonderful lecture, and I particularly enjoyed the wonderful videos that you showed in this. The dissection were very beautiful. The intricate dissection of the tumor, the vasculature dissection, they were all very wonderful. Now we are open to discussion and any comments for Professor Zhang.
Ahmed, we can invite our discussions, Professor Alberto and Alexander, for their comments first.
Yes, sure. Professor Alexander, do you want to start or?
No, I will be after you. Okay, please, you can start.
Okay, thank you. So I also want to congratulate Professor Zhang for a very nice presentation. I also enjoyed the videos very much. Beautiful cases and wonderful surgeries with great outcomes. I have a few comments for the discussion and also some questions. So my first comment is about the role of endoscopy in the management of hydrocephalus and diagnosis. So I totally agree with you that it is important to be able to handle an endoscope in the ventricles. I think these pineal region tumors are a perfect indication for ventricular endoscopy, as in just one surgery, we can fix the hydrocephalus problem of the patient. So we can have our patient to be free of symptoms due to hydrocephalus. And at the same time, we can also take a biopsy and clarify the diagnosis in most of cases. But you showed actually the use of a rigid scope, which implies a choice, which is the choice between one bar hole to do both maneuvers. This is less invasive, let's say, more simple because you just use one bar hole, but you have to accept some, let's say, stretching over the fornix to reach the posterior part of the third ventricle. And the other option is to make two bar holes, which is safer on the fornix because you don't stretch, but you have to transpass the brain with two different trajectories. I have my own philosophy, which is the use of flexible scope. Nowadays, the new flexible scopes are wonderful. They have a quality of image which is same as, if not superior, to rigid scopes. And with just one bar hole, you can do both procedures, ETV and biopsy, using only one trajectory and without any risk on the fornix. So this is my first comment for discussion. The other comment is about the management of a dilation of ventricles or hydrocephalus before actually resecting the tumor with a microsurgical approach. So obviously, when there is hydrocephalus, it is mandatory first to deal with hydrocephalus. We can do that using endoscopy, as we said, ETV, or sometimes with an EVD. So as I use for this kind of tumors the semi-sitting position and the infratentorial supracerebellar approach, in this kind of approach, but also in the approach you showed with very nice modified lateral position, in these approaches, the head is over the chest. So the risk for having pneumoencephalon is a real risk. And sometimes this pneumoencephalon is a hypertensive pneumoencephalon. It might happen. I also remember one case we had at my institution of hypertensive pneumoencephalon. So if you have an EVD performed before surgery and you have a hypertensive pneumoencephalon after the major surgery, you have no way to control this hypertensive pneumoencephalon. So I am in favor of ETV. I have to say that I like ETV in these patients. But some colleagues told me that they had tragedy just trusting EVDs in these cases, because if you have a hypertensive pneumoencephalon and the patient is still in the ICU, intubated, you might lose the patient for hypertensive pneumoencephalon. So they claim for the superiority of an external ventricular drainage placed before surgery to control eventually the hypertensive pneumoencephalon, and then remove this EVD maybe 2 days after surgery when the patient is well awake. So I would like to know your opinion about this problem, because it's very controversial. When I talk with many colleagues, especially pediatric neurosurgeons, I found very different opinions about that. Some are really supportive on ETV And some others say it's better an EVD because you can better control the situation of the intracranial pressure. And finally, my final comment is about the use of endoscopy during actually the resection of the tumor. I liked your technique very much. I think endoscopic assisted removal of these tumors through a very natural corridor like the infratentorial supracerebellar is wonderful. I guess in that way, so with endoscopic assisted removal, you are able to spare the veins which are between the cerebellar surface and the tentorium much better than using a microsurgical approach. So I would also like your comment about this advantage of using an endoscope instead of microscope. Thank you. Congratulations, very nice presentation.
First question.
Yeah, the first comment, it was a comment more than a question about the use of a flexible endoscope to perform both ETV and biopsy. So you can do both through a single bar hole without any stretching on the fornix. I don't know if at your institution you have a flexible scope, or what's your opinion about that?
In the paper, some surgeons use 2 hole to do ETV and biopsy. But in our department, if the tumor very large, we can use a hole to do ETV and biopsy. Because the tumor if the tumor enlarge, the tumor may be very easily we roof of the endoscope to the poster to biopsy the tumor very easily. So if the tumor very small, we don't use biopsy. We to resect the tumor very easily. So we don't use biopsy.
Yeah, so I guess that's why you use only rigid scope, right? So with the rigid scope, maybe it's difficult to reach the posterior part of the third ventricle if the tumor is very small. So yes, I agree there is this limitation. Yes.
Thank you.
Okay, adults.
Okay.
So maybe adults something. Please.
Thank you.
Thank you.
First of all, it's very difficult to comment after Professor Filete. He covered almost all the aspects of this presented cases. But first of all, Professor Zhang, thank you very much for great presentation. You showed the excellent technique of surgery, and I want to emphasize the importance of your technique, the microsurgery and the endoscopic control. And really, by using endoscope, you can avoid the main disadvantage of supracerebellar approach. You do not need to retract, and you do not need sacrifice the bridging veins for this. And as I can realize, you almost do not use the supratentorial approaches for pineal region tumors. And my question is, what are the main characteristics or features of the tumor which make you to use supratentorial approaches? Because I see that almost all tumors using this techniques supracerebellar approach, you can remove almost everything. But when do you decide to use supracerebellar approach?
I mean pair of the theta and eta bridges. Inferior tentorial and superior tentorial.
Supratentorial approaches, excess. Supratentorial. When do you decide to go supratentorial?
Superior tentorial we can is the from on to null to expose the pseudoventricle. May expose many part of the pseudoventricle, especially
More
of the
deeply.
anterior
I
wall
got
of the pseudoventricle. Sometimes we
Yes.
also may use with resect the tumor. We also will do ETV to the anterior part of the.
I understand. Because in my practice, I'd consider the subchoroidal, transventricular subchoroidal approach for tumor. But thank you very much. I was impressed by this technique you showed. Thank you very much. Thank you.
Thank you.
Yeah, we have a question from Professor Salazar here.
Hello, thank you so much for the opportunity, Professor Zhang. Congratulations. It's really beautiful what you are doing, your technique, your results. And I have a couple of comments about what Professor Faletti said. I guess the management of hydrocephalus will depend on whether the patient is compensated or not regarding the hydrocephalus. Sometimes we know that if they are come at night, 3 a.m., we don't have maybe the endoscope, so the resident maybe will have to do some type of procedure to control the hydrocephalus. So in those cases, when I know that I won't be able to do an ETV the same day, the same moment, I rather use the ventriculoperitoneal shunt. And maybe my preference is to choose the frontal horns, and it will depend on the side of the tumor. Sometimes the tumors tend to go whether the right side or the left side. So if I see that maybe it's not in the midline and it's whether on the right side, I would prefer to go to the contralateral side to the frontal horn. So I will put it in this case in the left frontal horn, for example, because I don't want to any of the distal catheter to interfere whether the access I will do. So I will put it as far as I can. If I know that the patient will, for example, have the MRI that night, and for example, the next day I could do the surgery, to go to take the tumor out, I will prefer to manage it with an EVD. For example, when I know that I have the endoscope, my preference is to do the ETV, as you all said. And my preference is to go to the same side of the tumor. I actually would like to know Professor Zhang's opinion and Professor Faletti, because, it's a debate whether you do it on the same side of the tumor or to the contralateral side. I guess for me, it's more comfortable. I guess we have a little bit more space if you do the ETV on the same side of the tumor. And when, regarding the choose of the approach, for example, to go in an occipital transtentorial approach or a supracerebellar infratentorial approach, I guess for me it depends whether the vein of Galen is compressed downwards, for the tumor. In that case, I will go in an occipital transtentorial way. And if the vein of Galen is upwards, pushing up tumor, the vein, I will go maybe a supracerebellar infratentorial approach. If I have to choose, it's a rule, to put the tumor side down, to help the gravity and to go for that side of the approach. If it's in the midline, that sometimes it happens, and I will go, for example, in an occipital transtentorial approach, I would prefer to go to the left side because I'm a righty, so ergonomically it's a little bit easier to go on the left side. You don't have to cross your hands. And and I guess the debate will also be when you use the ETV, would you do the biopsy first or the ETV first? So in my practice, I guess always would be the ETV first, and as a bonus, to try to get a biopsy of the tumor. I have seen so many cases that you take the biopsy, start to bleed, and if you didn't do the ETV first, sometimes you have to abort the procedure and, put an EVD and everything gets complicated. So that will be my comment. Thank you very much, Professor Zhang, once again, because of your wonderful technique.
Yeah, thank you, Professor Salazar. Any comments from Professor Kato, Professor Shah, Professor Avda?
The comment for the Dr. Salazar? No, maybe Dr. Tan. Can you reply to him?
What?
Any opinion to the Dr. Salazar, the comments? So my small question to you, thank you very much, Dr. Tan, the wonderful the presentation, congratulations. So how much percentage you can combine with radiotherapy? Because sometimes it's very dense touch of the vein. Sometimes you can remain the tumor, you need to remain the tumor. So how much percentage? Maybe they limited the cases, I think.
Well, radiotherapy very
Yes.
useful to geminoma. I found if we as a pre-operation operative diagnosis think the tumor is pure geminoma, geminoma, pure geminoma. We if the and also the geminoma is very large, we may use bypass because it is very useful in radiotherapy. But many tumor is mixed tumor, mixed ECT. Especially the tumor is mixed and with a small part of the geminoma. We also resect the tumor. If the sometimes the geminoma is often invasive of the normal structure, such as ICB. So we may consider of the safety. We may lift some part of the geminoma. Maybe use radiotherapy. It is very safety.
Thanks so much. Thank you.
Thank you.
So, Ahmed?
I think Dr. Fawad is here to say something.
Okay. Assalamu alaikum. Konnichiwa.
Konnichiwa.
Thank you. Thank you very much. Great presentation and congratulations for your achievement. I just like to know that's the possibility of training for Afghan neurosurgeons and also donation of neuroendoscope for Afghanistan. You know, we are now in restriction and sanction, and one option is you that can help us for training of Afghan neurosurgeons and also for neuroendoscopic surgery and also for donation of endoscope as well. Thank you.
Okay, thank you, Dr. Fawad. Any comments from Professor Kato? Alberto would be saying in here something.
Yes, I just want to comment on Professor Salazar's comment, if I can. So I totally agree with you, Professor Salazar, about the priority of ETV first over biopsy when you do an endoscopy in these cases, because the first aim, of course, is to fix the symptoms of the patients, and the symptoms most often come from hydrocephalus. So we need the patient to get better from symptoms. And if you do biopsy first, your vision might be impaired and you might not be able to fix the hydrocephalus problem. So I totally agree. About the use of ventriculoperitoneal shunt, I have to say that I never use VP shunt, at least upfront, in these patients because it's an obstructive hydrocephalus. So I reserve VP shunt only later on after the management, of the tumor, in case I have communicating hydrocephalus for some reasons, like impaired reabsorption. So in that case only I use VP shunt. I also agree with you about the fact that it depends on the setting, which technique you can prefer. Sometimes they arrive at night, there is a resident, he's not able to perform endoscopy. So in these cases, of course, if there is nobody able to manage the hydrocephalus with an endoscope, an EVD, I think an EVD is a good option. In my practice, I usually manage these cases with depending, of course, on symptoms. So if I have an exceptional case, a setting like it's coming overnight and a young resident is at the hospital and the patient has symptomatic hydrocephalus, of course, EVD for sure. And then we will think the day after how to manage the problem of the patient. But if I can fix the hydrocephalus problem immediately, I do endoscopy with a flexible scope and ETV and later biopsy. The point is what to do with the patients who have dilated ventricular system but no symptoms correlated directly to hydrocephalus. Is EVD or ETV justified in those cases or not? So sometimes when the patient has other symptoms not related to hydrocephalus, I go for major surgery first. Of course, if imaging is not giving me some doubts about the nature, the germinomatous nature of the lesion. So sometimes we do surgery up front, very rarely though. We prefer having a biopsy in these cases. So in general, I prefer, if I have to manage hydrocephalus, doing ETV, and then post-operatively, after the major surgery, I want my patient to be awakened very soon so I can have a clinical control, just to avoid missing the situation of a hypertensive pneumoencephalon, which is really can be a tragedy. So if the patient cannot be awakened immediately after surgery, I prefer placing an ETV after major surgery through the same bar hole I used for endoscopy.
If I may
Thank you,
comment.
Alberto. Yeah, any comments for it?
Yeah,
Professor Zhang?
I was just hearing the conversations, and I realized that very esteemed comments from Dr. Zhang and Alberto. Of course, when there is also a possibility that in, as you said, the hydrocephalus is always related to obstruction. So once it's examinable, when there is a tumor highly radiosensitive like germinoma, and the obstruction is going to be naturally relieved. So the options there are plenty, as you said, ETV, also EVD. But when we were in Japan, we saw a very interesting case where Prof. Watanabe used to insert the Omaya reservoir into that burhole where the biopsy is taken. So this can be removed very easily. So it was very novel thing for us to see, because since several years we always have been resorting to either EVD or ETV for this patient. But Omaya reservoir as an EVD is also a very good option.
Thank you, Raja. I think Omaya is the answer to us also in most of the cases. If it's good to go, I've just a couple of very small questions to our esteemed panelists and to Professor Zhang. Is there any specific surgical consideration that you consider for pineal region tumors in pediatric and adult age group? Second, how do you balance the need for aggressive tumor resection with the risk of morbidity, as the resection of these tumors particularly are prone to for severe morbidity in some of these patients? So, any comments or any answer for this?
I didn't get your point. Sorry, Ahmed.
Is there any specific surgical consideration that you consider for resection of pineal region tumors in pediatric and adult age group? Is there any specific surgical consideration that you consider?
I see Professor Salazar wants to answer maybe.
Dr. Zhang,
For example,
can you-
I have used an histopathologist at the same time during the surgery. So in some cases, we take a little biopsy of the lesion, we send it to the pathologist. In that moment, he revises the specimen, and sometimes he says, "Well, it's a germinoma, teratoma, whatever." And depending on the result, maybe we stop the surgery, and no, we go afterwards to some adjuvant therapy. So in those cases, we don't look for a total resection. I saw in Professor Zhang's video that he manages to, in every case, to take all the lesion out. I guess, maybe in his hands, his heels allows him to do that, but maybe at least us, when we have a pathology that we know that can have a radiotherapy, chemotherapy, solution, we stop the surgery and, we wait for the adjuvant therapy. But we need the pathologist in the room. If he's not there, we try whenever possible to take out the lesion. If we see that it's, a little bit complex, we will stop and, to see the result later.
Yeah, thank you. If we are good to go, shall we move on to our next speaker now?
Yes,
Yes,
so
Ahmed.
but before that, I
Yes,
think
thank you. It was a wonderful discussion. Yeah,
Okay.
Gato.
Yes, thank you. So maybe I think Dr. Fawad, maybe I think you can send the young doctors to Dr. Zhang's place, I think, as a fellowship. So Dr. Zhang, can you accept Afghan fellow for your hospital as a fellowship?
What? Adi?
Can you accept the Afghanistan young doctors as a fellowship for your hospital?
I wish.
Okay,
May I accept that? May I
Okay,
accept it?
thank you very much. Okay.
Thank
So
you.
maybe Dr. Fawad, maybe you can write to him, please. Okay.
Thank you.
Okay. Please proceed.
Okay, thank you. So our next speaker is Dr.Nazmin Ahmed, who's an assistant professor and a consultant at Department of Neurosurgery, Ibrahim Cardiac Hospital and Research Institute, Dhaka, Bangladesh. She'll be speaking on ongoing challenges in the management of high-grade meningiomas, current scenario in Bangladesh. Dr. Nazmin, please go ahead with your slides.
Hello, me Dr. Nazmin Ahmed. Can everyone hear me?
Yes, we
Yes,
can.
you're good to go.
Okay. So I'm now going to share my screen. So is my screen visible to everyone?
Yes, please go ahead.
So me, Dr. Nazmin Ahmed, I am working as an assistant professor in the Department of Neurosurgery, Ibrahim Cardiac Hospital and Research Institute. And currently I am doing my fellowship on skull base and vascular surgery under Professor Iko Kato in Fujita Health University, Bantana Hospital. So before going for my presentation, I want to express my heartfelt gratitude to Professor Kato for inviting me to say on management of high-grade meningioma in this prestigious webinar. So all of the neurosurgeons have some good idea about what the meningioma is, so I am not going in details. So this meningioma comprises 20% of all primary brain tumor, and among them only 1 to 3% tumors acts as high-grade meningioma according to the WHO classification. So these high-grade meningioma share distinct radiological features, molecular characteristics, as well as their history characteristics. So their overall management remains really challenging for especially for a young neurosurgeon like me. So still now we are in the era of targeted therapy, but Though we live in this status and numerous advancements have been already taken in the management of different entities in the neurosurgery, but still maximum safe surgical removal along with adjuvant radiotherapy plays a vital role in the management of high-grade meningioma. So if I consider the meningioma burden in Bangladesh, still now there is no cohort study available addressing the epidemiology, management strategy, and outcome of high-grade meningioma in Bangladesh, as it's a densely populated country, but no study still available. So we have designed a prospective cohort study, which started from the 2016 after obtaining approval of our IRB board. And we are proceeding for purposes sampling technique for this. So the patients having proven high-grade meningioma in the histopathology as well as immunohistochemistry, those patients including in this study. So today, I am sharing some 5 to 6 cases, representative cases in this presentation, in which they have some distinct atypical radiological features, some surgical challenges we have been gone through, as well as their postoperative outcome. So in this regard, this is my first case. He's a 60-year-old male, right-handed. He presented with our department with the features of left-sided weakness for only 15 days. So on examination, he has left-sided hemiparesis and muscle power was 4 out of 5. So very short history, which is not opposed in favor of some benign lesion. So this is the MRI, which has been done in 2023, this last year. Shows there is a huge 6 into 5 centimeter lobulated extraaxial lesion in the right frontoparietal region, and the T288 image, there is heterogeneous picture, and if we see the tumor cortex interface, there are multiple branching flow voids are evident here. So after administration of the gadolinium, there is heterogeneous contrast enhancement. You can well appreciate the lobulated appearance in these images, and dural tail sign is also evident. So from the imaging, it's evident that it's a kind of meningioma. And this is the intraoperative picture. If we look at the bone flap, there is the small features of infiltration, but there is no distinct osteoblastic or osteolytic reaction evident. So we have, this is the cross macroscopic appearance with attached dura matter. So Simpson grade 1 resection ensured. And histopathology came with the features of grade 2 atypical variety meningioma, and patient already received 54 gray radiotherapy in 30 fractions. And he has complete neurological recovery, and the images CT scan, follow-up CT scan in 2024 done complete resection as well as no residual or recurrence of the tumor, and the patient is doing fine till now. So my next case is 61-year-old female, right-handed, and she presented with right-sided weakness for 1.5 months. So she has a neurological deficit in the form of right-sided hemiparesis. The muscle power is 4 out of 5. So this is the MRI of the brain, showing that there is 5 into 4 centimeter. This tumor also exhibit a lobulated appearance, the parasagittal falcine location. So after administration of the contrast, it has heterogeneous contrast enhancement. In the GRE, this is some kind of blooming artifact is there. And if we consider the MRV, there is hypoplastic left-sided transverse sinus is already evident, but there is no infiltration of the superior sagittal sinus noted. So we achieved gross total removal. And this is the appearance of the bone flap, and the right side, this is the macroscopic appearance of the tumors, this multiple lobulated appearance. So we achieved Simpson grade 2 resection for this lesion. It's the cut surface. So this patient experienced post-operative CSF leakage as we are unable to close the dura in watertight fashion. So her adjuvant radiotherapy was delayed for 3 months. So for management of the postoperative CSF leakage, we have placed a lumbar drain and keep it for 3 to 5 days, keep it for 5 days. And after that, the problem solved, and now she is on adjuvant radiotherapy. So my next case is a lady of 35 years old with no history of prior radiation, presented with intermittent dull aching localized headache for 2 years only. So she was neurologically intact, except there is features of papilledema. So in the MRI, it's evident that there is a well-defined predominantly hypointense lesion in the T1 weighted image, which become hyperintense in the T2 sequence. And if we look carefully, there are multiple flow voids, intrinsic flow voids, as well as some marginal flow voids are evident here. And after administration of the contrast, there is bright homogeneous contrast enhancement. So this is the CT angiogram of the patient with 3D reconstruction showing that all some feeders are coming from the branches of the middle cerebral artery. So some kind of pile feeders are there. So this patient underwent Simpson grade 2 resection in 2017, and her histopathological report was consistent with chordoid variety of WHO grade 2 meningioma, and she already completed adjuvant radiotherapy dose and achieved complete neurological recovery, and her headache subsided completely. So this is the MRI, follow-up MRI, which I have done in 2022. Patient is completely fine. So my next case is a 46-year-old lady. She is a known case of papillary carcinoma of thyroid and presented with progressive enlargement of the palpable hard mass in the frontal region for 2 years and convulsion for the several episodes for the same duration. So one thing I want to mention here that 2 years back, when she diagnosed as a case of papillary carcinoma of thyroid, there was a small palpable lesion also in the frontal region. And after going to a CT scan, it's evident that there is she was suspected having a case of intraosseous meningioma, but as the lesion was small, she underwent whole brain radiation therapy for this. And there is progressive enlargement of the frontal lump for 2 years. And when it becomes cosmetically ugly, she presented to us, and this is the MRI of her brain showing as a huge tumor with the bifrontal location. And if we look carefully at the T2 weighted images, there is no distinct tumor cortex interface, and brain seems to be invaded. There are some peritumoral edema and huge mass effect. So there is also multiple intrinsic flow void are also evident here. So after administration of the contrast, there is heterogeneous contrast enhancement. There is intrinsic features of necrosis as well as involvement of the bone and invasion of the scalp as well. So this is the MRV. If we look at the MRV, there is obliteration of the anterior 1/3 of the supraoccipital sinus with development of the multiple collateral venous channel. So this is the bone flap. This bone flap reveals both osteoblastic, outer surface has osteoblastic changes, and the inner surface there is osteolytic bone reaction. So we discarded this bone, and patient underwent Simpson grade 2 resection. This is the postoperative CT scan of the brain showing complete dissection of the tumor, and we went for polymethyl methacrylate cranioplasty for this patient. So this is very unusual for a primary intraosseous meningioma with this aggressive behavior, for which we have already proposed a clinical classification for these aggressive tumors. So my next case is a 45-year-old lady. She presented with progressive left-sided hemiparesis for 2 years and convulsion for several episodes for the same duration. So on examination, this patient also exhibits left-sided hemiparesis, and muscle power was 3 out of 5 according to MRC grading. So this patient first did her MRI in 2016, which shows a huge right-sided parasagittal meningioma. There is heterogeneous intensity of the tumor in the T288 image, as well as there is features of peritumoral edema and a mass effect. And after administration of the contrast, there is almost homogeneous contrast enhancement except the central iso-intense area noted. So no dural sign. This is the MRV. If we look carefully at the MRV, there is complete obliteration of the superior sinus in the middle third, including the middle third. And there is a prominent draining vein, collateral draining vein is noted. So during operation, we have achieved Simpson grade 3 resection, and there is accidental injury in that part of the draining vein. So after operation, this is the CT scan of follow-up CT scan of brain in 2021. So at first, the histopathology report came anaplastic meningioma WHO grade 3. We have counseled the patient to receive adjuvant radiotherapy, but due to some familial issues and economic constraint, patient denied for undergo adjuvant radiotherapy. And we lost follow-up also. So from 2016, this is the CT scan done in 2021. Submit well, and there is some encephalomalacic changes, probably as a consequence of that brain injury. But she improved her muscle power and achieved 4 out of 5 and was seizure-free till 2021. So in 2022, I again went for MRI of brain with contrast as a follow-up protocol. So it's evident that there is a small recurrence at the previously resection area. So at that time, she received radiotherapy, completed radiotherapy. So in the 2023, when patient suffers from several episodes of convulsion, she again came to me, and I did MRI of brain with contrast, and this is the picture. There is multiple recurrences at the previously resected area. There is a scalp invasion as well as features of metastasis in the C2 spinous process. So also look at the complicated disease course for this patient. This patient completed 3D conformal radiotherapy in these doses, and also we have tried tyrosine kinase inhibitor for this patient. But despite of having all these efforts, she has multiple metastases. I have already shown the year of detection and site of metastasis here. So there is extensive metastasis. In 2024, she experienced pathological fracture of the femur and underwent open reduction and internal fixation surgery. And in 2000, just expired, this patient unfortunately expired just the last month. So this is my last case. The 45-year-old lady presented with sudden onset of severe headache for 7 days and convulsion for 1 episode. And fortunately, she was neurologically intact. But if we look at this patient disease course, in 2016, she underwent left temporoparietal craniotomy and gross total removal of meningioma, and the histopathology was WHO grade 2. And in 2021, there was tumor recurrence. So she again underwent craniotomy and gross total removal of the recurrent meningioma, and she underwent both of the surgeries outside our facilities. So when I received this patient in 2023, she has lost most of her documents. So I could not put the previous any images in my presentation. So I'm sorry for that. But when I received this patient in 2023, this is the MRI of the brain with contrast. So it's evident that there is a mixed intensity lesion in the previously resected area. This is the craniotomy margin, which become mixed intensity in T288 images, but with surrounding some perilesional edema. It may be consequence of radiotherapy also. So after administration of the contrast, there is heterogeneous contrast enhancement. There is a lobulated or bilobed appearance. The smaller one shows more homogeneous contrast enhancement. However, there is no dural sign noted. So before going for operation, if we carefully look at the radiological picture, I was a bit confused whether it's meningioma or some other pathology may coincide with this. So this is the operative bone flap and the tumor. This is the smaller component. So that was the solid component. And this is the well-capsulated hematoma, and the dura mater is attached here. So I cut the hematoma cavity inside. It's filled with some kind of subacute blood. And this is the capsule. And this is the tumor component I have marked with blue star. So in this scenario, during third time resection, we removed the lesion with dura. And as the bone flap seems to be relatively okay, I have replaced the bone flap. And patient, so she underwent third time resection in 2023, but to my utmost surprise, the histopathology with immunohistochemistry was consistent with glioblastoma WHO grade 4. So she goes to India in 2024 and verify her slide again. So at that time, the histopathology was consistent with WHO grade 4 glioblastoma. So she is on now-stop regimen. So I have published already a book chapter regarding this atypical picture management of high-grade meningioma, what is present, past, and promising future. So we all know about the other therapies, therapies other than adjuvant chemoradiation. I am not going in details because everyone much more expert than me. Just I am highlighting some points. So what is the current scenario in Bangladesh? So in Bangladesh, we have facilities of radiotherapy, chemotherapy, as well as immunotherapy for this patient, but with a limited amount in government hospitals, especially in the private setting, we have much more limitation as there is no insurance coverage. So most of the cost should be bear by the patient himself or herself. And there is also some lack of awareness, and counseling of the patient party is also a bit difficult. So the management, overall management of this high-grade meningioma is really challenging for us. So I have already mentioned the point, already. So what are the learning points for the young neurosurgeons like me? That is what is the aim of my today's presentation is just surgical expertization needed, as there is frequent involvement of the venous sinus infiltration, brain invasion, intratumoral hemorrhage. There is poor tumor cortex interference and some kind of osteolytic as well as hyperostotic bone reaction. So there are so many changes. Atypical features can be present as in high-grade meningioma. So beside this, there are also features of tumor dedifferentiation. I have already shown that in my last case, the tumor was initially grade 2 meningioma and her previous 2 resection, but it became grade 4 during the third time resection. And also, according to the literature, after surgical resection, even the tumor characteristics can be changed. It can be converted into grade 2, 3 from grade 1, or even metastasis can be evident. So frequent recurrence or even metastasis necessitate regular follow-up and multimodal management. So expert supervision needed in every steps of management. Also, proper counseling is needed. So with these words, I would like to conclude my presentation here, and thanks to all for your patience hearing.
Thank you, Dr. Nazmin. Wonderful demonstration of your cases. And I think all of the cases that you showed were of giant meningiomas, as is obvious, the late presentation of the patients in the subcontinent region. Of course, one thing you must have noted that all of these high-grade meningiomas that you have shown, all were superficial tumors. None of the what I have seen and what I have felt is none of the skull-based meningiomas that that the most of us had encountered, we have never presented them as high-grade meningiomas. So obviously, I think there must be a link between superficial tumors and superficial meningiomas and they being high-grade. We are now open for discussion from our discussants now. Professor Alexander, Dr.
Yes,
Abda.
yes, I'm ready. Dr. Ahmed, thank you very much for a great presentation. Excellent cases, good job. Thank you very much. I'd like to only highlight some problems with the high-grade meningiomas. The problem is that even in cases we are maximally radical at the surgery, the tumor will recur at the locus of the site of surgery or by means of remote metastasis. In my practice, and I guess the most complex meningiomas, especially high-grade meningiomas, are located at the skull base. And the second group are the meningiomas which invade the venous sinuses. It's the biggest problem to make a decision what to do with the meningioma which invade to the sinus and doesn't occlude it. It's for me it's always a problem because sometimes we can perform the plastic of the wall when we have a minimal invasion. When it's bigger, when it is impossible, it's very difficult to repair the possible defect of the sinus. So, and that is why in my practice, I think it's a most challenging point for the high-grade meningiomas I operate on. So that's, thank you very much. Thank you for great presentation.
Thank you, Prof.
Go ahead.
Thank you. Maybe I am fortunate enough that till my 15 cases, they are mostly involves the convexity and parasagittal location. So most of the cases, we are able to achieve Simpson grade 2 resection. But obviously in the skull base, that would be more challenging and obviously difficult one. So I'm totally agree with you, Professor.
Thank you, and I wish you to have more and more difficult and successful cases in your practice.
Any comments from Professor Salazar, Professor Kato, Professor Abda?
Well, thank you very much. Congratulations to Professor Nazmin. It's a nice experience. I guess you're doing very well with your results. I guess the main thing with meningiomas is that we have to try to get as much as we can. That means we take out the dura, maybe 2 or 3 centimeters of the last margin that caps contrast. No, so we have to see the contrast imaging, with detail, because sometimes the dural tail, it's maybe 2 or 3 centimeters away from the margin of the tumor. And from that margin, you have to calculate maybe 2 or 3 centimeters more to resect the dura. So in these convexity meningiomas, parasagittal meningiomas, you have to, I guess I like to do big incisions. So I have maybe a lot of fascia to do the duroplasty when I can. You have to do, as you have shown us, a big craniotomy, so you can take as much as these osteoblasts, as much as bone, infected bone as you can, so to prevent the regrowth of these tumors. And I guess what would be, for example, in your experience, when you have, as Professor Wozniak said, a tumor that is not infiltrating totally the sinus, or maybe in some cases that you have seen the sinus is involved, you try to be more conservative, maybe in those cases take what you can and then go to radiosurgery, for example. Or you might see and wait, for example, if that little piece that you left in the sinus, it's growing or not, and take some images in time to see if it grows, and if it grows, you try to do it again or send it to radiotherapy? What would be your protocol for those tumors, for those cases?
So I want to mention one of my observation. In my fifth case, that was young lady, have a right-sided parasagittal meningioma. In that case, we achieved Simpson grade 3 resection, and there was complete occlusion of the middle 1/3 of the superior sinus. So after incising the venous sinus wall, there may have a thin layer of residual tumor, I guess. So when she came to follow up in 2021, no tumor, fine. But in 2022, there was evidence of recurrence at the similar site. And this patient, I have observed the extensive metastasis in 2024. That is metastasis in the lung, liver, C2 spinous process, as well as femur. So in that case, sinus infiltration might play a predisposing factor for this extensive metastasis. So I am expecting your expert comment from the panelist that in case of parasagittal meningioma, when there is complete occlusion of the sinus or infiltration of the venous sinus, what should be our protocol in this regard?
Okay, it's question for it's a question for us. Yes, yes. Yes, thank you.
As
I told you, I told you
what
that it's
should I
a very challenging situation, which you must decide at the time of surgery. Of course, if the tumor, if the sinus is occluded completely, I try to resect it, but it's not always possible. Sometimes because of big draining veins, which are adhered to the sinus, and so it's very difficult to be maximally radical. What I do technically, I use the ultrasound aspirator with on the high power, and I remove everything from the sinus with the ultrasound aspirator until I get the bleeding from above and below. Then I cut, and then I block the sinus and remove all the invaded part of the sinus. It's the more challenging, the difficult situation when there is the blood flow in the sinus. In these cases, of course, I do not recommend to be maximally radical. Only in cases when you see the very small invasion, and you are sure that you can repair it with the surrounding tissues by resection, and then by putting the stitches. For example, how I do, I just put a stitch, start to resect the invaded wall, and resect part of the tumor. They put one stitch, then remove another part of the tumor, put another stitch, and step by step, I go down and resect the invaded part of the sinus. But in general, I do not recommend to be aggressive with invaded sinus if it's not occluded completely, and also what is very important, with the surrounding bridging veins. So it's very dangerous to sacrifice any of big draining veins around. It's
Yes. Thank you so much.
You're welcome.
Yes, Dr. Fawad, any comments?
Assalamu alaikum.
Walaikum
Thank you very much. Great presentation and good achievement. Just I like to know about the radiotherapy. We haven't possibility of radiotherapy in Afghanistan, unfortunately, destroyed during the war. But your experience showed us even with radiotherapy, there is recurrence of meningioma. I like to know all of our professor's idea about doing radiotherapy for meningioma or not, because when recently I operated.
I think Dr. Fawad is pleased on.
His connection is not good.
Yes. Any more comments?
So Dr.
I think there
Nazmin, that
is.
was a good presentation, very nice presentation. So what I think Dr. Fawad was asking is, after you do a meningioma and the histology is suppose grade 2 or grade 3, would you straight give up? You've done a good total radical resection. Would you still go ahead and give upfront radiotherapy, or would you wait for it to recur? What is your strategy?
So thank you, Professor. I had a good time with you in Bangladesh and tumor cadaveric dissection. Okay, so now coming to your question, I referred this patient to oncologist, and in my country, though patient underwent gross total resection, our oncologist preferred to give radiotherapy. Though literature, according to the literature, there are diverse clinical results. Some groups concluded that in case of grade 2 tumor, gross total resection along with radiotherapy possesses a better progression-free survival as well as overall survival. And beside this, another researcher published their results that there is no effect of radiotherapy if there is a if the surgeon achieved gross total resection. So there is no difference. But beside this, radiotherapy possesses some disadvantages also. So two different school of thought there. But my country, if I consider the tradition of my country, our oncologist prefers.
Okay, we generally do not give upfront radiotherapy. We would wait for some time if you're in a good radical resection, because only when a meningioma has breached the dura, when it has breached the bone or reached up to the bone and caused a bony reaction, and then the histology is probably grade 2 or grade 3. Those are the more aggressive ones in our experience. And so if they recur again, then of course we will consider radiation after operating the recurrence rather than just giving upfront radiotherapy.
Yes, I think it's a wonderful discussion. One thing that needs to be pondered upon in these high-grade meningiomas, in a very small subset of these meningiomas, apart from the sinus invasion, how to deal with it, as Professor Alexander has told us, there are still a subset of patients in which there is so much huge bleeding right from the start of incision of the skin that we don't even that it becomes really difficult for us to reach the dura level. In those subset of patients, I do strongly believe that just removing the bone, opening the dura, and leave it to a second stage after 4 or 5 days or after a week to take the tumor out is very, very beneficial in those subset of patients, especially in the subcontinent region and in those centers in which where embolization is not readily available. I think Dilshad has something to say in here. Dilshad?
Yeah, thank you so much. Yes. Do you hear me?
Yes.
Yeah. Thank you so much, Dr. Nazmin Ahmed. So my question is, have you had an experience of using preoperative embolization of feeding vessels for giant meningiomas? In case we know that devascularization can be very problematic, and maybe this is kind of option to facilitate tumor resection.
Thank you for your question. The question is very much justifiable. I am completely agree with you that in case of giant invasive highly vascular meningioma, if we go for selective embolization of the feeders, it will facilitate surgery and minimize the intraoperative hemorrhage. That's a great advantage. But in my country, I worked in a private setup. So every cost here beared by the patient himself or herself. So if I combine the preoperative embolization along with surgery, the total cost will be very high. And sometimes despite I know that if I would go for preoperative embolization, this will facilitate surgery, I could not go for, considering the cost. But the scenario is a little bit different in our government hospital. They have the facilities, and some of my colleagues are doing excellent outcome in case of high-grade meningioma, because they have the facilities and cost-effective also. So it's a difference in government and private setup work.
Thank you.
So,
Jeremy, is Jeremy in here? Something to say?
Yes, thank you, Najmin. Sorry, I think I have issues with my phone. I am also one of the fellows who is with Dr. Najmin at Fujita and Professor Yoko Kato. I just want to congratulate Najmin for the wonderful study that she has done. One of the questions I wanted to ask, over and above the extent of resection of these tumors, the molecular pathology of the meningiomas is also important. And I think
yes.
one important marker that you want to get is the Ki67 markers. I don't know if you've been able to do Ki67 markers for these meningiomas.
Yes. I have gone through every cases because this is a high-grade meningioma when histopathologically proven. I have gone for immunohistochemistry analysis for every cases and referred these patients to oncologist and keep regular follow-up. At least I have tried to maintain a database of these high-grade meningioma patients. Yes, I go through.
Thank you. Any final comments from Professor Kato?
Nazmin, thank you very much for excellent talk. I think that you were a good teacher, and also that you learned a lot. Maybe that you can teach us about the meningioma, because we have so huge meningioma we have. We will just operate in 1 week. Thank you very much.
Thank you, Professor, for your great appreciation. You have given me the opportunity to learn from you in Fujita Health University, and after reaching here, I have already seen 2 cases of preoperative selective embolization for bilateral parasagittal meningioma. This is a new learning and observation for me, and I convey my heartfelt thanks to you.
Thank you.
Thank you, Dr. Nazmin, for your wonderful lecture. We now move on for our next speaker, who is Professor Byron Salazar, who is the neurosurgeon in chief at Quito, Ecuador. He is the past president of ACNS as Secretary General at FLAN. He'll be speaking on Pterional approach, anatomy, how I do it, how I use it. Over to you, Professor Salazar.
Thank you very much. I'm gonna share my screen. I'll try to be fast also. And let me see. I don't know if you are watching my screen.
Yes, we can see it.
Well, thank you very much, everyone. First of all, I would like to thank the organizing committee, and especially Professor Yoko Kato for their kind invitation to this international event. And I would like to share with you some thoughts about anatomy, technical aspects, and application of the pterional craniotomy, and principally how to avoid complications. Now, the pterional craniotomy, described and popularized by Professor Yasargil in the 70s, has become the most useful and versatile approach in neurosurgery. So it was a pleasure for me to share his 99th birthday in Turkey during the Yasargil Microneurosurgery Academy meeting in Istanbul this year. And one of the requirements to understand the approach is to identify bone and vascular landmarks. So it is important to build a three-dimensional knowledge of the anatomy of the brain, to have an X-ray vision or see-through concept in which the anatomy of the structures located in the depth can be envisioned using anatomical landmarks and located on the surface. So, of course, we know that the main landmark of this approach is the Pterion, which is the region of the frontosphenoidal suture, the sphenotemporal suture, the sphenoparietal suture, the squamous suture, and the coronal suture. So, according to this paper by Murphy, there are multiple variations of the Pterion. So it has to be understood that the Pterion, it's a region and not just a point. When we look at the Pterion, we have to see what's below the Pterion. So under the Pterion, we found the anterior Sylvian point. So the pars triangularis points out to the anterior Sylvian point, and deeply of that point, it points into the lumen of the insula. So that's where the middle arterial, the middle cerebral artery changes its direction from medial to lateral into an anterior-posterior direction. So it is important also that this anterior Sylvian point, it's a cisternal point in the Sylvian fissure, and it's usually the starting point for dissecting the fissure from lateral to medial. And of course, the center of the approach is the anterior Sylvian point. So when we know, for example, that the pars triangularis and the pars opercularis covers the anterior part of the insula, that's a landmark we have to know. Of course, the keyhole corresponds to the pars orbitalis, which is located superiorly to the orbital roof and continues as lateral orbital gyra in the basal surface. We have to know that the Sylvian fissure is represented in the cranial surface by the squamous suture. So we know the Sylvian fissure projects obliquely from inferior to superior, from medial to lateral, being parallel to the lesser wind of the sphenoid. So the highest point in the squamous suture, it represents the inferior Rolandic point. When we know that the superior temporal line meets the coronal suture, it defines the Stephanium. And this represents the end-to-side connection between the precentral gyra and the inferior frontal sulcus, which represents the area of the face on the precentral gyrus. So we know that the reach of the Pterional approach includes well-defined pathways, like the subfrontal approach, the transsylvian, the pretemporal, the anterior subtemporal, which allows us to get inside numerous intracranial structures like the insula, like the oncus, like the lamina terminalis, the interpeduncular fossa. So I would like to show you some cases that demonstrate the reach of the Pterional approach. So transcranial approaches still play a critical role in giant and complex pituitary adenomas, like in this case, which have intracranial extension. And we know, for example, that as a first step, we tend to initiate with a lateral subfrontal approach. And this is used to allow a safe passage to the basal cisterns like we see here, and drain CSF. And by opening these natural corridors, cutting the arachnoid, dissecting neural and vascular structures, we reduce the intracranial pressure and avoid the need to use a preoperative lumbar drain, for example. Of course, the transsylvian approach has several benefits, such as a shorter working distance. It's an anatomical familiarity. There is a lesser need for brain retraction with a wide Sylvian dissection. And as you see here, I do like to take my time to just cut the arachnoid with the tip of the scissor, to use dynamic retraction without the need of fixed retractors. And we can open the Sylvian fissure, starting at the anterior Sylvian point from lateral to medial. And in this case, as we said, the center of the approach regarding vascular and neural structures, of course, are the ICA, the optic nerve, and the anterior part of the oncus. So in this case, we found a post-fixed chiasm. And so I started to debulk it in a lesion through the interoptic space, the optical carotid, and the carotid oculomotor spaces, taking advantage of these natural corridors and taking the lesion in a piecemeal fashion. And here we see the final view and the final result here. And for this, another case for another cellular tumor, we used a different strategy. We found that, or we know that different strategies are further described in the literature to enlarge the windows and to expose different structures, like in this case, for example, when we have a prefixed chiasm. So the fenestration of the lamina terminalis is used, and it's a safe approach to the lesions of the third ventricle. And in this case, we could debulk the tumor through this pathway and other natural corridors. So here we see the final result in the visceral pathway, and in this specimen from Professor Rotten, we can appreciate the reach of the third ventricle. And here we see the pre and post-operative views of the patient. Another case. In this case, we presented a meningioma that was located at the anterior incisorial space. It had a broad dural tail. And for this tumor, two main approaches were considered, a pretemporal or an anterior subtemporal approach. So we know that the center of the pretemporal approach is the third nerve. So this approach exposes the entire temporal lobe in order to offer the transylvian and lateral subfrontal views, along with the subtemporal and temporopolar views to access the interpeduncular fossa. So to achieve this, these bridging veins that we see here that drain the temporal pole and orbital surface to the sphenoparietal sinus and cavernous sinuses are sacrificed, so we can mobilize the temporal bone, the temporal lobe, as we see here. And for example, for this case, we decided to perform an anterior subtemporal approach. So we did a Pterional craniotomy and expanded to the temporal side as low as the temporal floor and drill it, like we see here. And after the craniotomy, we did a mini peeling of the temporal fossa, so the temporal lobe can be gently elevated and coagulate the branches of the middle meningeal artery and meningeal accessory artery to the vascularize the tumor, like we see here. And we took out the dura as basal as we could, and in an intradural fashion, we took the meningioma out and finished afterwards with a duroplasty. Here we see the immediate post-op, with a complete resection of the tumor, and the patient, afterwards without any deficits. So how to avoid complications during Pterional craniotomy? So regarding the skull complications, the most common are scalp lacerations, skull fractures, and epidural hematomas. So it is not recommended to use the head holder before the 3 years old. And as a general recommendation, we should avoid pins placement on vascular, nervous structure, or over the temporalis muscles. And here we present the two main correct positions to set the head holder, depending on what we want to do. And for example, if we want to have more space, not to be hitting the head holder in here, we have these two main positions. Of course, we have another complication, which is ocular compression that can cause blindness by thrombosis of the central retinal vein, especially in patients with shallow orbits. So the compression can be produced by the surgeon or by the resident's hand. So we have to be very careful where we put our hand, where we rest our hand. We can also produce blindness when tractioning the myofascial flap against the orbit instead of elevating the myofascial flap upwards. So we have to pay attention to this. Another complication is skin necrosis, like we see here. And this paper demonstrates that it is important not to overcoagulate the skin and subcutaneous tissue to avoid scalp necrosis, especially with the monopolar, as well as to try to avoid using hemostatic clips for prolonged times. Pterional craniotomy may lead to cosmetic problems, like we see here, due to bone loss, and of course the drilling of the lesser wing of the phrenoid, and also can produce a nasty scar marked with alopecia, especially for women and children. This can be, very upsetting. The temporalis muscle deformities, like we see here, are presented by nerve injury, by muscle ischemia, by prolonged retraction or interruption of blood supply. So direct injury of the temporalis muscle fibers. So an inappropriate repair of the temporalis muscles to the site of the original attachment, and it can restrict the mouth opening and chewing dysfunction. So as a solution, I prefer to use a scalpel and a blunt dissection for the detachment of the temporal bone, following the technique of Oikawa, because I think the monopolar produces more heat and more atrophy. So I try to avoid using this technique when detaching the temporal muscle. Of course, there are many alternatives for the reconstruction of the temporalis muscles. You know that there are many papers about that. And the most important complication is the palsy of the frontalis muscle due to the injuries of the frontotemporal branch of the facial nerve, presenting, like in this case, an eyebrow drop. And there are three main techniques to preserve and avoid injury of the frontotemporal branch of the facial nerve. We have the submuscular technique, the interfacial technique, and the subfacial technique. And according to this paper, there is an increased risk of frontalis nerve dysfunction with the interfacial technique. So one way to avoid this is to have a proper technique when doing the interfacial dissection to identify the correct plane of dissection, leave a 2 centimeter distance from the orbital rim, and aim to the posterior root of the zygoma, keeping the dissection behind the STA. Another complication is the injury of the superficial temporal artery, whether one or both branches. And what is the solution? The solution is to palpate and locate the STA and plan your skin accordingly, whether it's behind the artery or in front of the artery. And we have this interesting paper that in practice, the closer we are to the tragus and we begin the incision such as 5 millimeters, the less risk we have of cutting the STA. So what's the solution? As a solution, I try not to infiltrate the skin incision with epinephrine in the temporal region to avoid any vasoconstriction and to be able to identify better the superficial STA and vein. So if you cannot save any branch because it's difficult, you have to expose more, you can just cut the parietal branch and elevate the flap anteriorly. What's another complication? Frontal sinus injury, orbital entry, or may both occur during pterional craniotomy. Do a frontal and extension of the craniotomy, or in these cases that when the patient has a big frontal sinus. So the frontal sinuses are bigger in males and are bigger in the left side, according to this paper. And to avoid entering the frontal sinus, the supraorbital foramen represents the medial limit of the craniotomy. We have to respect it and not pass over it. What's another complication is an inadequate drilling of the lesser wing of the sphenel that we see here, in these pictures on the left, because it blocks the entry, as we see here. It blocks the view. It blocks the angle of attack to the basal cisterns. So after a pop drilling, like in this case, the dura can and is folded back and adapts itself to the bone surfaces, which is flat, totally flat, like we see here, without any formation of wrinkles and folds that might obstruct the view. So to conclude, the progressive implementation of technical advances associated with the upcoming technology has turned the Pterional approach into the most versatile approach. So great strides have been made in surgery during the past 4 or 5 decades, and most of them are related to the scientific advances and surgical technique itself. So we need to have a philosophy that shows our appreciation and gratitude for the unwavering support, guidance, and lasting impact of our mentors in our career. So it is important to remind us that to become good surgeons, we cannot forget about these important principles: the anatomy, the ergonomy, the technique, the technology, and of course, the philosophy of our mentors. Thank you very much.
Thank you, Professor Salazar, for your excellent lecture. I really like the problems and the solution portions. And of course, the last line that you said that I often remind to my residents that it's very important how you come out of the lesion rather than just opening it. Particularly true for Sylvan fissure. The art and beauty of opening a true bloodless Sylvan fissure is difficult to do rather easier to be said. We are now open for comments from our discussants now. Professor Alexander.
Yes, I'm ready. Professor Salazar, thank you very much for a great talk, for a great topic. Also, we know that the Pterional approach is a working force for surgery of big variety of anterior and middle fossa surgery. And thanks to Professor Xiaobiao, who developed this strategy, this idea of this approach, whole the world can use it more and more. I thank you very much for those that you discussed the real pitfalls of this surgery, and you recommended how to avoid the complications during performing this approach. You mentioned about the frontolateral trajectory and pterional. I would like to emphasize a little bit this idea for younger colleagues, because frontolateral and pterional are the absolutely different approaches. Do not confuse them. So, and I absolutely agree with you that this is an absolutely different angle, absolutely different syncope. And actually, even absolutely different risk of surgery. And the second thing I'd like to mention that as Professor Xiaobiao told, there are two types of Sylvan fissure. One type you can dissect, another one you cannot dissect. Unfortunately, sometimes you cannot dissect. So if you see that you cannot dissect, do not try it. Just stop and do what I recommend to do. I recommend what I do. In my practice, I extend my approach frontobasally by means of resection of the sphenoid wing, resection of the clinoid, opening of the optic canal if it's necessary, and by this way, by extending the tumor downwards by the technique skull-based technique, I have much better access to supracellular region and retrocellular region. This is my advice. In general, thank you very much, Professor Salazar. Thank you for a very good presentation.
Any further comments? Professor Abda?
Dr. Salazar, that was a fantastic presentation, and thank you for highlighting the pitfalls of the pterional craniotomy. And I agree with you on 2-3 points, and that is that no infiltration in the skin is a definite help in preventing any problems with the skin necrosis. We also do not use any cautery for the muscle, and I use the subfacial type of dissection for protecting the frontalis nerve, and minimizing the use of cautery and avoiding injury to the nerve and vascular supply of the temporalis muscle is the key for a good cosmetic outcome after surgery or after using the pterional craniotomy. Of course, we also use the subfrontal approach for a lot of these tumors where we do not go all the way to the pterion, like for a craniopharyngioma or hypothalamic glioma. Probably I would prefer the subfrontal approach. The trajectory is, of course, a little different because there I just need to open the Sylvian fissure at the base and not dissect it completely. Of course, in a pterional, I will have to dissect the Sylvian fissure completely. So just a few points here and there, but all in all, a fantastic presentation. Thank you very much.
Thank you, Professor Shah. And I know that when I was preparing the lecture, that you and Professor Goel published a technique for dissecting the temporal muscles from anterior to posterior. So what could you tell us about that technique?
So what normally when you start from the back and take it in the front, you make an incision in the temporalis muscle. So this is something like without an incision. You use your osteotome, a curved osteotome, and you roll the muscle back You just have to sometimes make a small incision behind, and you roll the muscle back over the zygoma. You're preserving the deep temporal branches that come to the from the base of the muscle supply, that comes from the base of the zygoma to supply the deep end of the muscle. So that is what you're preserving, and you get a very good access because that muscle bulk does not stop your access to the lesser wing of sphenoid. So that is what we generally.
And you didn't have any frontalis muscle nerve dysfunction? Huh? Okay.
Ahmed?
Yes, thank you. Any further comments?
Yeah, if I may say something, so much of emphasis is put on the frontal branch. So we usually what we do is we follow the Pineal line, which is the surface marking of the frontal branch of the facial nerve, which is 0.5 centimeters below the tragus and 1.5 centimeter above the lateral eyebrow. So if you draw a line like this, this is the Pineal line, which is the external landmark. So we avoid it after raising the skin incision. We take the facial plane over the temporalis just above this line and reflect it down with the skin. So that is one point I would like to make.
So basically, you take out the temporalis muscle along with the skin in just a single incision. That's what you're saying.
No. The temporalis muscle is there. We cut the when you cut the skin incision is here, right? From there you go deep to the facial plane, retain the muscle, and take the facial plane with the skin incision. Temporalis facial with the face.
Okay, thank you. Any comments from Professor Kato?
Okay, Dr. Byron, thank you very much for a great lecture. So at this time, the minimally invasive for the patient is very, very important because that is the patient wish. So maybe you mentioned from the beginning to the end, all point is very, very important. So otherwise we cannot fight with the endovascular or radiosurgery. So you pointed out so many important issues. Thank you so much. Great lecture. Demonstration.
Thank you so much, Professor Kato. Thank you for inviting me, and thank you all.
So I think we have come to the end of this session. I would like to thank Professor Kato, all the ACNS WIN team for this wonderful webinar in here, and all the speakers. They made wonderful lectures in here. All the discussants who participated and made wonderful comments over here. Thank you.
Okay. Thank you so much.
Thank you. Thank you very
so
much.
much.
See you next time. Thank you. Bye.
Thank you.
So